Good morning or afternoon, depending on where you're located. Thank you for joining us today for the webinar Preparing for an APM, What You Need to Know. My name is Michelle Brunson, and I'm with Telegen with the QPP-SURS program. This is a quality payment program for small, underserved, and rural support, and we support the states of Iowa, Nebraska, North Dakota, and South Dakota, but no matter where you are, we welcome you today. This is a repeat webinar from the webinar we had last week on July 26th. We heard a lot of positive feedback from the webinar, so we are so happy to offer this again today live. Now, before we begin, the slides for the webinar can be found on telegenqpp.com under the Resources tab for the July 26th link. So we will also post the recording from today's webinar, since we will have different questions at the end. And speaking of that, we've muted your phone lines, but you will be able to ask your questions at the end of the presentation. And you can also type your questions in the chat box, and we will answer those at the end as well. We are so excited about this topic here because there's so much emphasis for practices moving from fee-for-service models to value-based payment models. And we heard a lot about alternative payment models, or APMs, in the industry. An APM is basically a model of how CMS pays a provider organization based on quality and cost metrics. It can be confusing about what that really means. So we're also getting a lot of questions about APMs on our team and across the country, and even more the steps that a small practice can take to move into an APM. So we are very lucky to be able to invite an expert on this topic, Dr. Don Klitgaard. Dr. Klitgaard is a family medicine physician from Iowa. He is currently the CEO and CMO of Medric Advantage. They do consulting and ACO management. In fact, he founded Heartland Rural Physician Alliance and is the board chair and CMO of Heartland Physicians ACO. He has lots of experience in the ACO world and also a significant amount of experience in patient-centered medical home, which is a great precursor to the APM environment. He was a medical director for 16 years at Mirtu Medical Center in Harlan, Iowa. I'd like to welcome Dr. Klitgaard for being here today for his time and his expertise. What we love so much about this presentation is that he has the hands-on experience with ACOs, a type of an APM, and he gives very practical steps for practices on this topic, which is so welcome. So with that, I'll turn it over to Dr. Klitgaard.
Thanks, Michelle. I appreciate it very much. So look forward to speaking with you here in the next hour or so, and we'll get through the slides, hopefully present some useful information for you, and certainly, as Michelle said, leave room for some questions at the end of our time. So basically, I want this to be real practical. What are the things you need to know? Because there is lots and lots out there right now around APMs, and so we want to make this hopefully a very practical talk for you. Just so you know, I'm a family doc, practiced in rural Iowa for about 16 years, full scope family medicine, was medical director during that time. Transitioned, did a lot of medical homework at that point in our practice, became a regional and national resource on how do you transform the practice into patient-centered medical home, and then transitioned to doing more accountable care organization type work. Created an IPA here in Iowa to bring independent practices and physicians and hospitals together to do ACO-like work, to do APM-like work, and so that's really where most of my efforts have been in the last 4 or 5 years. So I currently am active managing ACOs, both Medicare and Blue Cross Blue Shield ACOs here in Iowa, consult with a lot of organizations regionally and nationally in that space. And I'm also faculty for many of the projects, including QCP-INSEM and some of those national projects that CMS has out there, similar to what's funding this, to kind of help practices figure out how do you make that transition well. So that's my background. Just so you know, despite doing this consulting and ACO management stuff, this is where my heart's always going to be. So when I think of this work, when I think of what do we need to do as practices, as hospital systems, as practitioners, to kind of adapt to and get ready for and function well in a value-based purchasing world, I always look at that through the lens of what's that look like for a practicing doc, especially a rural, small-town practicing doc, which is where I spent my career in active medical practice. I still do some ER shifts and keep current and active that way, although it's obviously transitioned to doing more of this ACO type of work. So what are the objectives today? Let's talk through trends that are affecting this move to value-based payment and alternative payment models. What's that really look like, and why are we at where we're at now? Right? How can you stay viable? Because we're right now getting paid pretty much in a fee-for-service world, but we're supposed to be preparing for and transitioning to value-based purchasing. And so what's that look like? How do you kind of stay viable in the current system while preparing for and transitioning into these alternative payment models? And what are those options? What are the various APM options out there? Pros and cons of each, some of those kinds of things. And one question we get real frequently is, how do you know if you're ready to join an APM, to join an ACO or another alternative payment model? And if you decided to move forward, how would you go about doing that, or what would that look like? So that's kind of a lot of what we're going to cover today. When we look at big picture, why are we here now? This really has a lot to do with it. The triple aim that CMS is really ingrained in their culture. Don Berwick brought that there, and it's sort of morphed a little bit over time, but stayed pretty true to that whole idea of better care and smarter spending and healthier population. And so this is really, if you're looking for a blueprint of what do I maybe need to be thinking about as a practitioner, practice, system, whatever your role is, in healthcare right now, this is really sort of the roadmap for what's driving a lot of the changes. And I'd add to this the quadruple aim, because there's more and more, you hear more about joy in practice, about physician burnout, about, all of those kinds of things. And we've realized, in large part because of some of the failures with the EHR transformation over time and what that did to practices and to practitioners, that we can't do those top three without understanding how that impacts the clinicians, the people actually providing the care, the physicians, the nurses, the staff, the offices, those kinds of things, right? And if we don't kind of add that quadruple aim of improving the clinician experience along with doing those other things for healthcare, we won't get where we need to be. So really the underlying theme or trend in payment is value-based payment. And when you hear that, value is usually defined as some type of quality. Often it's specific clinical quality metrics or outcomes. Sometimes, though, that's talked about in terms of safety or in terms of patient experience. Certainly is often at the top of the list of that as well. So what we're looking for is improved quality with lower cost. And you look at this kind of an equation, if you remember back to math, right? So you can get higher value with either keeping the quality the same and lowering the cost, right? So we're doing as good a job as we're doing today at a lower cost, or we improve the quality for the same cost that we're currently spending on the healthcare we're providing. That would also increase value. And obviously, ideally, what we're looking for is how do we improve that top line? How do we improve quality in all those metrics while at least holding the costs the same and hopefully appropriately and where possible decreasing costs as well, at least being smart about how we spend the money we spend in healthcare. If there's any question in your mind about where things are moving and about how CMS is trying to drive this train, you don't have to know all the details of this slide. This is actually a CMS slide, not my slide. Important points are left side is current state, sort of where we're at now. Right half is future state, where CMS predicts and is trying to get us to go, right? So if you look in the current state side of the slide, that big orange dot there, that's fee for service. So that's how, in large part, many or most of us get paid now, right? Maybe some version of that with cost-based reimbursement and that, but payment not necessarily linked to quality and value from a CMS standpoint, right? As you move through those categories left to right, you can see, well, the red dots are fee-for-service, but has some link to quality and value, maybe some PQRS kind of stuff. You can kind of think MIPS, some of those kinds of things. You're still getting fee-for-service, but there's starting to be a tie-in to you're going to get paid more if you do better, those kinds of things, right? The purple dots are more if you think about APM, so what we're talking about today. So you're talking alternative payment models. Now, it doesn't mean fee-for-service goes away. We still get fee-for-service in today's world, but more and more payment is likely going to get shifted to those alternative payment models that, while built on fee-for-service kind of architecture to begin with start to with more teeth, transition payment to being tied to quality and cost and value. And then category 4 is, there are some, say, Medicare Advantage plans where organizations are getting paid a certain amount to care for this patient or this population of patients, and it's really a population-based payment. Call it capitation if you want. That's sort of what we're talking about, and you can kind of see as you look on the right-hand side of the slide, this is where CMS is going, right? So fee-for-service maybe doesn't go away completely, but it shrinks dramatically, right? And more of how we get paid from payers, because CMS has made this slide, but you can bet the rest of the payers are going to follow CMS's lead. That's usually almost always what happens. So when we think of how we're going to get paid for healthcare in the future, this is really the way the payers are driving things, right? So more and more tied to quality and value, and eventually maybe to more of a population-based payment kind of mechanism. So this isn't going to happen overnight. It's not going to be complete, change from A to B in one fell swoop, but this is the way things are moving. And so we have to get comfortable with understanding how do you function well in that red world and that purple world, getting ready for a world that's payments more in the green category 4 kind of thing. So that's really what a lot of this is about. And that's how, honestly, we're looking at our participation in alternative payment models is that's how we're preparing. That's how we're learning the knowledge and getting the skills built into our practitioners, into our practices, into our organizations to be able to do well moving forward. The docs at least, and a lot of times the staff and everybody else is kind of always feeling like this, man, you're just asking me to do one more thing, right? I got a limited amount of time. I'm feeling overworked and overburdened and all that as it is, and here's, 1, 2, 3 more things. You're just adding more things to the list, right? So this is lots of times where we've been and where what we felt like as practitioners and as organizations sometimes, we have to really look at this as how do we get off this bus? How do we re-envision the care we're providing, and how can we make it so that our payment models don't just add to this kind of EHR syndrome of death by 1,000 clicks and, have to do more and more with less and less type of thing. So to that point, how do you stay viable moving ahead? So what are some key concepts you need to think about and questions that you need to maybe ask yourself, kind of reflect on for individually as providers or especially as practices and organizations, be that, hospitals or larger healthcare organizations, whatever fits you here, what should you maybe be asking yourself? So some of the big concepts are how can we appropriately maximize fee-for-service revenue. So right now we're getting paid largely fee-for-service. Are we doing a decent job there? Because we know we have to be getting ready for this other stuff, but we can't, shoot ourselves in the foot and die in the process, right? So am I doing a decent job maximizing current fee-for-service revenue streams? Because CMS and other payers have put in place some kind of transition strategies within the fee-for-service system that we can use to be doing the right thing, be hiring the right people, be putting the right processes in place, and position ourselves well for going forward. And we'll dig into each one of these a little bit. But be thinking about, am I doing that pretty well? We have to start to think about aligning quality with cost. A lot of times, those are not things that are opposites. Those are not things that don't reinforce one another. Lots of times, higher quality care truly is lower cost care. Now, sometimes with prevention, with some things, you pay a little bit more up front to do the right thing, but lots of times you more than save enough on the back end. And when we start to become more accountable for the bigger picture of the care that's provided and not just, what's the fee-for-service, widget that we're making today, but are we really looking at overall costs over a period of time? We have to start to think like that. And are we doing the best job for our patients? Number one, because it's the right thing to do, and we want to take good care of all our patients. And honestly, that's why most of us went into medicine. That's why people are in healthcare and doing what they're doing. But we have to start to see where can we align those efforts to lower cost, partly for the whole system. So Medicare doesn't bankrupt us so that our companies aren't paying so much for healthcare. They're not competitive in the market anymore, so that, our patients individually and as families aren't getting killed by these horrible healthcare costs that are getting covered less and less. So there's a whole lot of reasons why we need to start to think about and understand and deal with cost in a more definite way than we have necessarily in the past, and we have more information and more resources to be able to do that now. And then how you position for value-based purchasing. What am I doing today that's getting me ready and positioning myself in that practice for our success in that kind of world of tomorrow we looked at on the CMS slide. So you may have heard this quote before. I've heard it before. I guess I always thought it was probably Bill Gates or Warren Buffett or somebody like that, right? No margin, no mission, kind of a hard-nosed business kind of thing, right? This is actually who said that quote. It's attributed to Sister Irene Klaus, who was the CEO of the Daughters of Charity, obviously a nonprofit, very mission-based organization involved with healthcare as well as other social needs, right? And what she understood and what we have to really kind of come to grips with and understand is we have a social mission in healthcare, right? We want to take the best care of our patients and the populations that are in our charge and the communities that we're serving and those kinds of things. And most of us, that's kind of core to who we are as healthcare providers. But if we don't worry about the margin, if we don't think about the dollars and the costs and do that smartly and well, we're not going to be able to fulfill that mission. And that's going to become more and more true going forward as we move from fee-for-service. You can just see more patients and make up the difference to a world that's truly based on that value-based purchase stuff. So, how do you look at maximizing fee-for-service opportunities? We'll walk through each of those things we talked about there appropriately. So we're not talking about, how do you get on a hamster wheel and crank out more visits and do more and more and more just to kind of take advantage of a fee-for-service world, right? What we're talking about here is what are those opportunities that are right for patient care and also are good for the bottom line in a fee-for-service world, right? And also then start to align with what we're going to be asked to do in an alternative payment model. So lots of CMS coding opportunities out there now that, again, tie to this transition to value-based care. So are you getting your CMS folks in for an annual wellness visit? Sometimes those are seen as less valuable. Don't have the physical with it, it's harder to organize. How do you bill that separately? I mean, there's issues around annual wellness visits, but I'll tell you, number one, it's a good revenue stream. But number two, and more importantly, you do uncover significant important things about your patients if you take the time to actually do that and do that well. We think we know everybody well, but we uncover things in the process. And we'll talk a little later as you get into our alternative payment model how important it is to not only have all the diagnoses that you're caring for that patient in your EHR, which obviously continues to be equally important, but you have to put those diagnoses on a super bill so that patient can be appropriately risk adjusted on the Medicare side of things so they can know how complicated, how ill, how sick, what kind of health conditions that patient is dealing with and budget that appropriately. We didn't have to worry about that in the past, right? We just kind of did our thing and put enough codes down to support the level of office visit that we were seeing for the day. More and more we have to start to think about, we have to tell the insurer how complex those patients are so that the budget is set appropriately, and we can get into more detail on that going forward. There are other codes like transitional care management codes. If you're seeing them back right after a hospitalization, usually better payment from a Medicare side and also the right thing. And if we can prevent them from winding up back in the ER or back in the hospital because we saw them timely, we got paid better for doing it, we did a good job, reconcile meds, talking through problems, all of that kind of stuff. It's the right kind of care, but it also helps in a value-based world, right? Similar with chronic care management codes, there's issues around who does it, how do you document it, how do you make sure you're getting everything right and all of that. But I'll tell you, it's a great revenue stream. It is something, especially if you build it into your practice as a primary care practice anyway, that can be a great fee-for-service revenue stream, be doing the right thing for your patients and helping manage costs on a value-based purchasing side as well, in an alternative payment model. Chronic disease stuff, follow-up visits, labs, are you collecting co-pays, are you doing the right stuff right in the fee-for-service world? So those kinds of things are important. Are you offering prevention? Are you doing immunizations, lab screens, cancer screenings? Are you being comprehensive in what you provide preventatively? That's also good revenue streams, but the right thing for the patients. Think about commercial payment changes. Do you have insurers, the Blue Crosses in your state, United, the other folks that you deal with on a regular basis that have quality bonuses or pay for reporting or other types of pre-ACO, maybe some enhanced payment if you're a patient-centered medical home. Lots of different parts of the country have many different types of these sorts of programs. Research them, look into it. What are the payers in your area doing? What can you what can you take advantage of and be part of as you are thinking about moving into an alternative payment model, or sometimes it's in conjunction with those things. So this is the coding stuff that I mentioned before, right? You have to start to think about coding differently. We're used to how we think about it in fee-for-service. You have to start to think about coding, how we communicate with the insurance company, how much work we've done, and how complex that patient is. And if we're not very accurate, we're really telling the insurer we didn't do as much work as we did, and these patients aren't as complex as they really are, right? And this can translate in a fee-for-service world into a lot less payment. So if you think about, as medical director, we kind of had different personalities and different coding practices, right, in any group practice. So sometimes you'll have some undercoders, which, they just keep it simple, half of everything. The real simple stuff's a 212. If it's a little more complicated, it's a 213, and I really don't think about it much beyond that, and that's how I code. There's the lazy coders where everything's pretty much a 213, and, I don't really worry about it beyond that. And then there's folks that probably are more appropriate in how they code. Real simple, brief stuff, maybe 10% 212s, maybe a higher percent. A lot of what we do in primary care maybe is 213, but have a subset of fairly complex patients I'm managing a lot of things on, so we'll code those as a 214. So this is kind of fee-for-service thought process, right? But in a fee-for-service world, that makes a difference, and if you can get your providers understanding this is a good first step if you're not already doing that, right? You can kind of see your overhead stays the same, but what you collect and what your net income is changes drastically if you're the undercoder versus the lazy coder of all 213s versus probably what's more correct coding. Exact same care, same patient, same number of visits. Everything else is the same. The only difference in this scenario is how well people took how accurately they did with their coding and how seriously they took kind of taking a minute or two to do that. So even in a fee-for-service world, coding is significantly important. So start to think about are office visits being coded well. If you're a practice manager or a leader in the practice, a medical director, or any of those kinds of things, do you have some way to audit and evaluate that? Are you giving your providers support and education about coding? And I'll tell you, once a year, once every 2 or 3 years is not enough. You gotta maybe once a year once they get clicking, but you really gotta think about how you're doing that. And it's always been important in fee-for-service, like that last slide showed, but I'll tell you what, it becomes absolutely critical because of the risk adjustment piece of value-based purchasing like ACOs or other alternative payment models, and we'll talk about that a little bit more. So what about that whole idea of aligning quality with cost? What's that look like? So often high quality can mean lower costs, so you look for those opportunities. What are some projects you could do? Like if you're gonna do a quality improvement project in your office to say we're gonna try and improve something, why not pick something that aligns well with fee-for-service revenue streams, with getting ready for an alternative payment model? For example, are you doing something around the annual wellness visits? Do we know who those patients are that haven't had one? Do we have a plan in place to outreach to them? Same thing with chronic care management, follow-up after ER visits, follow-up after hospitalizations, those kinds of things, chronic care follow-up visits, prevention, immunizations. Any of those things are good things to start to look at and pick one and go through a QI project, go through a PDSA cycle and say, we're going to change how we approach this because we think this is some low-hanging fruit. This is a good opportunity for us, and we're going to improve the quality of care we provide in the process. But we're also going to be sort of thinking in the back of our mind, we're also going to address costs. We're also going to be getting ready for participation in alternative payment models in the process. Quality is a team sport, so this is not something that your practitioner, your doctor, your ophthalmologist, your optometrist, your chiropractor, your whoever, it's not just the person in charge of the care of the patient, face-to-face in that setting kind of thing. This is everybody, right? So this is, from your front desk folks to your medical records folks to your nurses that are rooming patients and dealing with stuff to your people on the phone, depending on what process and what quality indicator you're looking at. All of those people need to be involved. for the providers especially, kind of thinking about it is how can I get them involved and engaged in moving forward with this. Lots of times that's the biggest question I get from administrators or practice leaders is, I can't get, they just look at this as one extra thing to do. I can't get these docs to do anything different and all that kind of stuff, right? So my thought process and my recommendation for you would be, both for your providers and your staff, add as many hooks as possible into those process changes that you're doing. Make it a true quality improvement project. Make sure you know you're going to get skill building for your whole practice team. That's going to be important to the leaders in the practice, right? But for the individuals, make sure they know you can set these projects up. You get CME. We've got a QI project going on in our ACO practices right now, where we're trying to improve our rates of colonoscopy screening and mammography screening for colon and breast cancer. We scored low on those indicators. Almost every ACO includes that as a quality measure. It's a good fee-for-service revenue stream for hospitals or systems, right? It's the right thing to do for the patients. You're preventing bad stuff from happening. And at the same time, we have those process change quality improvement projects set up, so each of our doctors gets 30 hours of CME credit just for being part of this quality improvement project. The nurses get 30 hours of CEU credit. The doctors get MOC Part 4 credits. That's their board certification process. You got to do these Part 4 credits, every so many years. And so we have one project that's the right thing for patients, that it's addressing costs, it's improving our quality metrics, and it's also giving the docs CME, the nurses CEU, Part 4 credit. Everybody gets to be part of the win because everybody's part of the process. So you see improvement and you celebrate it. So it can be a team building activity and a skill building activity for your whole practice. MIPS, if you think about that, most of you have had to deal with MIPS likely at this point, right? You probably have your results from 2017 back, so you know what your score is, and you know what your percentage increase of your payment's going to be for 2017, or the 2017 number that will affect your payment now in 2019. So if you haven't figured out how to look that up yet, certainly connect with the intelligent folks or me or whoever, and we can get you directed to the right thing. Hopefully everybody knows that already. But how did you do on the MIPS reporting? That's an effort to align quality with cost, right? Did you report okay? Were your results pretty decent? Do you know what changes happened in 2018 that's going to affect this year? Some of those kinds of things. When you start to look at that first year in 2017, 60% of that MIPS score was quality, 15% was the improvement activities, 25% was the advancing care information, meaningful use, right, how you use your technology stuff. This current year we're in right now, right, quality went to 50%, cost went up to 10%. Starting next year, it's slated for quality to go down to 30 and cost to be at 30 from there going forward. And so more and more you're going to be held accountable for cost as well as quality in a pretty equal fashion, right? So it's important to kind of start to think through what's that look like for your practice. This is just a graph that kind of shows that. First year in the first column, this current year we're in now, it's a 50% quality, 10% cost, and then starting performance year 2019, so starting this coming January, right, for next year, next calendar year, that performance year, 30% quality, 30% cost will sort of be the breakdown for what CMS is likely going to hold us accountable for. They do have the authority to change those percentages on a yearly basis, but all the indications are so far they're probably going to stick with this kind of scenario. And just to remind you, depending on what that MIPS score is, most people didn't get anywhere near to a 4% increase, even if they scored really, really well. I think the highest ones I've heard of are in the low 2s, but, your payment can go up if you do a good job. It can go up a little bit if you do just an okay job, and it can go down. This is a zero-sum game. This is a closed system, so there's not new money coming in. So for all the people that are getting a 2% increase, there's an equal number of people that are getting a 2% decrease or some combination that add up to that, right? And then going forward, the stakes get a little higher each year. So we're currently in 2018. That affects our payment in 2020. So 5% up or down, 7% and 9% going forward. So Yeah, just kind of, I think you probably know this MIP stuff. You're going to get you get the final score. There's a threshold that's set. If you get above the threshold, you won't get a negative adjustment. If you get below the threshold, you will. If you get really down below the 25th percentile, you get a maximum negative adjustment. They do have some additional dollars supposedly in the pool for the exceptional performers, although I think there was such a large number of people that probably fell in that exceptional performer bonus pool this year that the numbers to any given person or any given group were fairly small. That performance threshold was initially set at 3 for 2017. The exceptional performance threshold at 70. As you can see, they went from 3 to 15 for our current year, 2018, and you can bet that that number is going to continue to rise, and if a lot of people are scoring really high, it'll probably rise pretty dramatically going forward. So anyway, that's sort of the CMS game plan for starting to, even if you're not in an alternative payment model, to tying quality and cost to payment, right? So just to give you some examples as you move into value-based purchasing, so if you move into an alternative payment model, how does that look different from the MIP score stuff, or what's that start to look like? So I wanted to give you, sometimes it's helpful to sort of have an example of, I had no idea what that would look like if I was in an ACO, right? So for example, in an ACO, in our ACO, one of our goals was to reduce ER visits. All right, how do you do that? Number one, you have a lot better data for who's been in the ER. You may have your local data, and you may have ER reports that get faxed to you from various places that your patients go. But when you're in an ACO or an alternative payment model, you get claims data. So we know all the ERs that our patients went to and when and how often and where, even if it was across the state, across the country, whatever, we have a good handle on where they've been, right? So then we being the management company for the ACO, provide reports to our practices that highlight in their interactive online in Tableau. So you can see in my practice who are my patients that have been to the ER more than once this year, twice, 3 times, 4 times, 5 times. We'll drop down menu. You can just choose your threshold, and you can start to narrow down. If we were going to outreach to some folks that have been using the ER a lot, who are those people? And you can very quickly find that type of stuff. We work with hospitals to get ADT feeds, so real time when people show up in the ER, we get a notification that they're there. Now that's been pretty hard in Iowa where we are right now. We don't have a good system to get statewide or national ADT feeds, but we're getting closer, I guess. Things are moving that direction. That's certainly part of the thought process, right? Most practices have developed direct communication workarounds with ERs where the patients commonly use and that kind of thing, right? So we look at what are our office processes. Do we have nurses, care coordinators that are empowered to reach out to those folks, get them in quickly? What are the expectations and what are the standards that our clinic is going to follow, our ACO is going to follow, and when do we get people in and how do we do that? Develop better protocols and how that happens, and then target some targeted strategies and outreach to the folks that really start showing up there a lot. A lot of times you may know some of them. I thought I knew them all, right? But you know a subset of them because you see them in the clinic. But a lot of people are using ER and not coming to the clinic. And so finding those folks and figuring out is this a substance abuse issue or a behavioral health issue or, something else that's keeping them from getting care in the clinic is an important thing. And figuring out how do I communicate that to the patients so they know that they can and should call us first before they just go to the ER. There's lots of cultural issues. Sometimes it's a practice level. Sometimes it's a community level cultural stuff. And so you have to sometimes do some education and some real targeted things to affect those kinds of things. That's an example of how you might look at reducing ER visits. Similarly with skilled care costs, what that look like. Same kind of thing. You get new data. You know what the costs are. You know what different skilled care facilities cost and how long patients are in there when they go there and who they are. And so lots of times skilled care in Iowa at least has not been very closely managed, right? The office process stuff lots of times is, I get a fax from the nursing home saying Betty Jones has been in the nursing home for 7 days, she needs more care, sign here to renew her skilled care stuff for the next 14 days, that type of thing, right? And I'll be the first to say, did I make a lot of phone calls when I got that fax on my desk? Did my nurse make a lot of phone calls? Did we check in with the nursing home to say, what's really going on with Betty? Does she really need to be in there, or for how long, or what's going on with her, and some of those kinds of things. Sometimes something as simple as a phone call to see how people are doing drastically decreases their number of skilled days. We see a lot of the critical access hospitals are more expensive per day, maybe for skilled care, but heck, they're only there for 6-7 days because we're managing them pretty well. Where they go in the nursing home, lower cost per day, but they're there on average 20 days because they stopped getting paid at 21, right? And so a lot of times we see patterns and trends, and we can start to look at it and intervene in some of those things differently and communicate with patients and families better. So part of this is just understanding the dynamics of what's going on with your patient population, the facilities you use, those kinds of things. So as you start to think about being part of an alternative payment model, some of those kinds of process questions asked and answers are important. So as you're working to maximize your fee-for-service stuff, you build out your knowledge base, your skill sets around cost and quality and risk. So the key question, a lot of people then end up saying, all right, I kind of get that. I don't, I'm not sure I completely understand it, but I get the idea. What are the benefits of being in an APM, and when do you know if you're ready to participate? So let's try and answer that a little bit. So alternative payment models, this is CMS alternative payment models now, are out there. There's a subset of those that are called mixed APMs. So in the Medicare shared savings ACO world, and in some of the other Medicare models, you don't take any downside risk. So like our ACO here in Iowa, we're a Track 1 ACO, so we don't take any downside risk. If we do a good job, we can get shared savings in our ACO, but we're not taking any downside risk, and that's really the kind of key factor that CMS uses when they look at alternative payment models as to whether you're a mixed APM, which means you're an alternative payment model, but you still do your reporting under MIPS, okay, versus an advanced alternative payment model, which we'll talk about in a minute, which means you're taking some downside risk, and because of that, then you don't report under the MIPS system, right? There's a little different pathway and a little different advantages and disadvantages for that. So what's that look like? So if you're in a MIPS APM, like our Track 1 one was, you do MIPS, but you get a little beneficial or optimal scoring. So number one, on the quality side, you don't have to report quality separately as a practice. The quality reporting you do as an ACO satisfies the quality reporting needs for MIPS. So there's not separate quality reporting needs for the practice. We're not held accountable for cost on MIPS because we're already held accountable for cost in the ACO. So that will always stay at zero for the MIPS APM. We won't get held accountable for cost separately on this scenario because we are being held accountable just by being in an ACO. The improvement activities, instead of 15%, is 20%, and you automatically get 100% of that score because you're in an ACO, and Medicare gives you credit for and assumes that by doing ACO level work like those ER and skilled care examples we just showed, you're doing improvement activities to try and improve quality and lower costs. You don't have to report those or do those separately. And then the advancing care information piece, each tax ID number, each practice does that individually, just like you would anyway, because you have to kind of do that with your own technology, right? So what about a Track 1 ACO? So most ACOs with Medicare are Track 1 Medicare Shared Savings Program ACOs. So that means have potential for shared savings if you do a good job compared to a benchmark that's set on previous spending patterns. You can get some pretty decent shared savings back as an ACO, which can then get funneled back out to the practice, right? You continue to get your current fee-for-service or cost-based reimbursement payments. It's not that those go away. You still get your normal payment throughout the year. It's just at the end of the year. If you've done a good job on quality and you've done a good job managing costs, now you can be eligible for sharing in some significant shared savings. There's no downside risk, meaning if you did a lousy job and you spent more this year than you did last year, CMS isn't coming and asking for a check, right? You have access to the CMS claims data like we kind of touched on a little bit. So you start to see where are the costs at in your practice. What's that look like? Where do those dollars flow to? Specialists, tertiary hospitals, other groups, look at it by practice, by provider, down to the patient levels. You have lots of data. You start to understand risk adjustment better and how important that is in the alternative payment model world. You get an idea of your local market and where your patients are going and what the costs are associated with where they're going. Right? So it really allows you to kind of participate and function well in an ACO without taking any downside risk, kind of get your feet wet with no real risk there. So let's talk through what this looks like in the real world. So just in general sense, I want you to really pay attention to this slide, because this is really, if you're going to move into value-based purchasing, be part of an alternative payment model, part of an ACO, this is really, you got to kind of ingrain this in your brain, because this is really like the biggest picture, most fundamental type of idea, right? Is how well you're going to do in that value-based healthcare world is really determined in large part, almost exclusively, by how well we understand and then actively manage these three things. So when you're in the value-based purchasing world, you have to understand quality. Are we doing a good job with quality? Are we managing quality well? Because you're going to be held accountable for it. Are you understanding? Do you know about cost and where the costs are, where the opportunities for savings are? How are we managing those opportunities and some of those kinds of things? You have to understand quality. You have to understand cost. And the third one is you got to understand risk, because risk adjustment is how the insurers, like Medicare or the Blues or United or whoever, is going to set the benchmark or set the budget for the ACO. So whether or not you get shared savings in large part depends on how that budget or that benchmark gets set, and that benchmark is determined in large part by how well we do coding diagnoses and telling the insurer how complex the patients are that we're caring for in our ACO. So what are some key learnings from quality? On the quality side, you just got to make sure you're being broad and holistic. The PCMH stuff really kicks in here. Are you aligning things well? Are you building out those principles of taking good care of patients and using the good solid PCMH principles as a sort of a foundation for building your practice and the care you're providing in your practice in a solid way? Each contract looks a little different when it comes to what the expectations are around quality. So the CMS quality metrics are different than in our state. We're in a Blue Cross Blue Shield ACO, so the quality metrics that Medicare uses are different than those of Blue Cross Blue Shield. There are some areas of alignment, so we look at that, which ones are in both, and how we probably ought to start focusing there, if we're going to have limited time and resources, right? But look at your baseline, see where your best chances for improvement are, be strategic in how you're looking at quality. Some of the things we've already talked about in your wellness business, transitional care stuff, prevention, immunization, team sport. We really covered most of these things, right? So that's the quality piece. Cost, have to work to get comfortable discussing cost. I know until a few years ago, as a physician, it felt wrong for me to talk about patients and dollars in the same sentence, and I almost got sick to my stomach or uncomfortable thinking about that or talking about that. Obviously, I had to get past that, right? What helps me the most, and I think the thing we got to understand as healthcare providers, is that usually, probably almost all the time, those folks that are the high-cost patients are usually the folks that we can have the most impact on, that probably need our expertise and our attention and our time and our efforts more than anybody, right? There are times when patients are just going to be high cost because of whatever diagnosis they have or whatever, but most of the time, those are the folks that really need us and really need us to be on the ball and doing the right thing for them. And so that helps me to understand that, that it's not just about dollars. It's really about the patient and about who are the most needy patients, who are the most vulnerable patients, who are the people that we can maybe really have an impact with. And lots of times those are the folks that also are the high-cost patients. There's a huge overlap between cost and quality, like we've talked about. Got to understand that the claims data is far from perfect, and I used to get hung up on that sometimes. It's, old, it's not accurate, whatever. Well, those things are true to a point, but guess what? There's a lot of good information we can use in there, and so we have to take what we can get and look at the patterns in there. We get good at, physicians, providers, healthcare professionals in general. We're pretty good at using our skills around pattern recognition and figuring out how to improve things, and so that's what this seems to be about. Understand your patients, the buckets of cost, what drives those in each community. Much of the ACO work is going to be, rightfully so, directed at cost. Again, don't let that put you off. It's also about patients and quality, and that's really what we're getting at here. And having that be physician-led and driven in our context is very important because you really keep the patient at the center. The access to the cost data gives us that extra perspective we just never had before. We couldn't see our own patterns of care and what decisions we made on a cost level basis and on a broader basis, and how different facilities or different subspecialists we refer to or different other things might cost significantly differently. Didn't have access to that information before. Don't make all our decisions fully on cost, but at the same time, we're going to be making those decisions, helping patients and families make those decisions. So understanding that piece of the puzzle in a more comprehensive, better way helps us and also helps our patients and families. And then the risk side is something you got to educate yourself on. It's probably the least understood of that quality cost risk thing. It's a new set of knowledge, new skills. Each contract looks different this way as well. But the key understanding is that what we code on our super bills and turn into the insurers, right, directly affects what the risk adjustment's going to be in that alternative payment model. Didn't matter as much in the fee-for-service world as long as we covered whatever office visit we had so we didn't get dinged, but now it matters significantly, and it affects in large part the success of the ACO efforts. You can do an awesome job on quality and an awesome job managing costs, but if you fall down and don't have a kind of a fundamental understanding of risk adjustment and get your coders and your docs to understand that, you may not see the full benefits of that at all. So we think about risk management, upside and downside risk. There's actuarial risk, so you have to kind of start to learn about different types of risk because that's being used in different ways in healthcare today. And the one that I would say that you really have to pay attention to, that we're going to kind of be held more accountable for and have more control over, is the risk adjustment side. You also have to understand if you're joining an alternative payment model, is it upside only risk in that sense being financial risk to your practice, right? Is it upside only risk, or is there some downside risk? If you don't do a good job and if the insurers feel like they've overpaid us, they're asking for us to pay that back. So those are kind of some general thoughts and concepts around risk, and we need to know that. So if you're an advanced alternative payment model, things are a little different. For example, Track 1+, Track 2, Track 3. Some states have CPC Plus, where they're getting upfront payments, but they also have some downside risk associated with that. There's a number of others that are being considered right now. So if you're an advanced alternative payment model, the good side is we don't have to do anything with NIPS. You get 5% of your previous year's Part B bonuses or Part B charges as a bonus payment, kind of a lump sum bonus payment, and eventually you're going to start to get higher fee schedule updates. So really, you got to kind of look at, where do I want to be? If I'm not in an APM now and I want to go into one, do I join that middle column, one of those mixed APMs where there's no downside risk? I can get some shared savings, but I still report under NIPS and that. Or do I consider joining an advanced alternative payment model? That 5% lump sum bonus always looks pretty good, but you got to realize that you're also, to get that, you're taking on some downside risk, which can be a problem. So, here's what we're used to thinking about. Probably a lot of people on this call, whether you're a office manager, or leadership, or nursing, or providers. These words all kind of resonate and make sense. Is what I was trained to do. This, though, is what we're now being asked to become increasingly familiar with and comfortable with, right? So what's value-based purchasing? What's risk? What's payment change? How do we rethink what we're doing? All those kinds of things. So just from a word puzzle type of thing, this is the stuff that we're touching on some today that we just have to start to dig through and get more and more comfortable with. So when do you know if you're ready to join an ACO? If you're asking the question, my thought is you probably are. You don't have to have it all together, be a high-functional, high-performing practice. Most aren't even close to that when they join their first alternative payment model. The most important thing is, are you willing to participate? Are you willing to learn? Are you willing to look at new data, take this claims data, this risk data, kind of make some sense of it, start to make some slow, gradual changes in your office, educate yourself and your practice about what's going on, look at how we could improve how we do things, and collaborate with others in the alternative payment model to teach each other, to learn from one another, to share best practices and those kind of things. And if you can answer that question of, am I willing to do some of that stuff and start down that road, then you're ready to join an ACO. How would you do that if you decide you are? Consider what your options are in your environment. Medicare versus commercial, Medicaid, et cetera. Do you want to join a large health system run ACO? Got to look at the pros and cons of that. If you're a smaller independent rural practice, like I think most of the people on these calls are, you might look around and see, are there any physician-led, are there any independent ACOs where they bring together, like we do in Iowa, groups of independent hospitals, independent practices, independent physicians into an ACO level, so they can do that good ACO work together, but not have to sort of give up a moderate or large amount of the control and decisions to a large entity, which most folks that are in the rural independent environment don't want to do. Is it an upside only or downside? Is there downside risk to that contract? And there's sort of a list of questions to ask to kind of think through who else is in it, how are decisions made, what are the costs, what support am I going to get, there's savings at the end of the day, how does it get distributed? Those are the kinds of questions that as you consider, an ACO opportunity or an alternative payment model of other types of opportunities, there's tons of things to ask. From a timing standpoint, it's important to know right now we're sort of in sign-up period. So most ACOs operate on a calendar basis, January to December. With the sign-up, adding people to the ACO for the next calendar year usually happening anywhere from May to July, August, September, depending on the ACO. Typically, Medicare has been as an ACO, we have to start to make decisions for next year and put in a letter of intent by May 31st and have most of those decisions made by end of July, middle of August. This year has been an unusual year that they have drugged their feet, and there's a bunch of reasons why, but that window is going to be later this year. So right now, what usually happens by the end of May hasn't even happened yet. So we're probably going to be looking at August, September for the sign-up period, the absolute end of the sign-up period, for next year. So if you're interested in joining ACO for next year, you still have a little open window there. So this is how a lot of the docs feel. Don't give in. Don't let them give in. Don't you give in as leaders in your practices. This is actually could be good stuff for all of us. We just have to understand it and manage it well. And so as you're thinking about all those complexities, just remember this is a process. This is an event. This isn't something that changes how we get paid overnight or what we're going to do overnight. But we have to start down that process and understanding it and participating in it and be ready for what happens. So I will end there where we still have some time for questions. Please feel free to either send in or ask your questions going forward here. I think they'll probably unmute things here.
Well, thank you so much, Dr. Klickar. This is just valuable, wonderful information. And I'll pause here for a moment to see if anybody on the line has some questions.
I had a couple that were sent to me through the chat privately that I could maybe start with.
Great.
One of them was our practitioners you bill for included in an
APM has unmuted your line.
So basically, from a CMS standpoint, for example, anybody that bills under your tax ID number is going to be, is going to be included in the ACO, right? Is going to be seen as sort of a provider in the ACO. If it's somebody that sees patients in your organization, but they do their own separate billing, doesn't matter if they saw them in your facility or whatever. It's how the billing happened. Is it billed under everything's tax ID number driven? So is it billed under your tax ID number? And anything that is billed under your tax ID number, those patients may well end up getting assigned to your ACO, depending, independent of who saw them if they were billed under your tax ID number. And then a second question was, how do you go about getting CMEs for providers and fees for providers in nursing in Iowa? So basically, we work with an organization called IPMA that makes it very easy to do they help us with a quality improvement project, and basically they are portfolio sponsors, so they can do the Part 4 credit. They're CME accredited providers, so they can give the CME and CEU credits for both the nurses and the docs. And so for us, that was what we found was the easiest way, is kind of a one-stop shop type of thing. I think there were probably other ways you could organize it, but that's how we found they had good resources both for the quality improvement work itself, as well as then the accreditation for CME, CEU, and Part 4 kinds of credits. And so I can respond to to anybody that, and get you some contact information if you have interest in that. So.
Great, thank you.
Michelle, I have a question.
Sure, thank you.
Excellent presentation, Dr. Clifford. When you talk about looking at new data and talk about claims data and risk data and actuarial risk data, et cetera, where if you're not in an ACO now and you really don't have all that information, if you join a shared savings, the Medicare shared savings ACO, will Medicare provide you with that data, or how do you go about getting that risk adjustment data and claims data?
Yes, if you're not in an alternative payment model, basically the only real source of information you have, like from Medicare, is your QRUR report. So if you're not familiar with that, that is at least a little bit useful, but it's very much, big picture overall. It's not as useful as it could be, right? So, yeah, the way you get access to the claims data is by joining an ACO. And so for us, every tax ID number that is associated with our ACO, and therefore every patient, basically we get data on we'll use the Medicare ACO for an example, every Medicare beneficiary that's assigned to our ACO through the tax ID number where they were seen the majority of the times. There's kind of a whole attribution process that happens. But basically, we get full claims data from Medicare on every one of those Medicare beneficiaries that is seen in our ACOs, right? And so Medicare gives that data to the ACO. Each ACO manages that information a little differently. So that's one of the questions you ask if you're going to join an ACO is, how are you going to get that information about your patients and your practice from the ACO? So, our management company, Medicare Advantage, we do that data analytics for our ACOs. And so we take this big file that Medicare gives, we break it down by practice and by physician, and we provide that to each of the practices in a monthly form, that they can then dive in as deeper or not if they want. We give them a whole series of reports on costs in some of those different areas, and it's an ongoing process where we talk as an ACO, what are our priorities, what other things should we be looking at. We do a lot of ongoing education and collaboration around what that looks like and what do you do with that information. So.
Okay, that's what I wondered. Thank you very much.
You're very welcome.
We may have time for another question. Dr. Clickard, I have one question. I think we just get this a lot. So what would you recommend a practice do right now if they think they're interested in joining an ACO but they're just not sure? Like, what would be that next step?
Sure. Well, I think, first step is look in your environment. Look and see what your options are, right? Because that varies a lot state by state, payer by payer, and that type of thing, right? And so I guess the first thing is to do a little research on what's available in your area. Lots of times that then turns into, on Medicare's website, for example, you can click on whatever state you're in, and it'll list out all of the ACOs that are actively running in that state and what their contact information is and what type of ACO they are. So you can kind of pull up that list and say, I really don't want to take downside risk, I don't think, but here's 2 or 3 options for folks that are doing a Track 1 ACO in my area, right? And so then reach out to those folks. I have a lot of conversations with individual physicians, with practices, with organizations that are considering participating in an ACO, in one of our ACOs. And so a lot of times that's just a dialogue and a discussion, and get questions asked and answered and get familiar with what, what your opportunities are, who you seem to gel with, who fits well, maybe their philosophy and their approach to the ACO work seems to work well with, your thoughts and your plans, and who do you feel comfortable with being a partner going forward in this ACO work.
That's great. And also, I'm going to put on in the chat Telegen has a listing of all those APMs that are available in our 4-state area, and you can send that out, send me an email at mbrunson@telegen.com, and I'll send that list. We should have that posted to our website soon as well. So,
I mean, I'll just put out there that if anybody has questions, I'm always happy to, even if it has nothing to do with us in our APO in our area or whatever. I mean, if you have questions in this world or whatever, about APMs and ACOs and all that kind of stuff, feel free to shoot me an email and I'll try to either answer to get you directed to who can as well.
Well, we just can't thank you enough, Dr. Klitschgar, for this wonderful presentation for both last week and this week. And we appreciate all of your time and expertise and your willingness to help answer those questions now or ongoing. And so thank you. And thank you as well to everyone else for attending. And we really appreciate it. Have a great afternoon. Bye-bye.